It's wonderful to have Claudia here for many reasons. First, she's the president of EASP. Second, I have to say that despite all our efforts, and not because of any conscious effort on our part, Claudia, you're the first lady speaker we've ever had. We've had two others booked, but something went wrong. And last year we had Joe Zaku, oh, 2 years ago, we had Joe Zaku was so ill on the day with vertigo that she couldn't speak. So we're really glad to see and that you're here safe. Claudia, anyway, as well as being president of EASP, is a professor in neurology and consultant in neurology at the University of Würzburg in Germany. Her research interests are in immune neuropathies, the pathophysiology of pain, and antibody-mediated diseases. And she has interests in clinical issues like fibromyalgia, CRPS, and cytokinins. She has, of course, published and written extensively, including books, and she's deputy editor for the European Journal of Neurology. And we gave her a title, which wasn't very kind. 56 years on, are we any nearer to closing the gate? And she said, I don't really want to speak to that. So we cajoled her. And I don't know whether she's going to speak to that or whether she's just going to tell us what she thinks. But anyway, it's a phenomenal honor to have you here, Claudia, and thank you so much for coming.
Thank you very much for the kind words. I will try to share my screen. Can you see it properly? Yeah, okay. Thank you. Thank you for inviting me to give this prestigious speech to honor Ron Melzack. It's a real pleasure. As you said, when I was invited, I told you that being the present ISP president, I'm of course very proud to be allowed to honor one of the founders of ISP. However, I also told you that my research is quite far away from spinal cord circuits, and I'm also not a psychologist. So when I was asked to answer this question, whether we are closer now to closing the gate, you might not get the answers that you expected. But I found this sentence in the original publication on the gate theory that helped me. And the sentence goes, we believe that the interactions between the gate control system and the action system described above may occur at successive synapses at any level of the central nervous system in the course of filtering of the sensory input. So with this sentence, I can find my place in researching on the gate, and I just looked at some of my research, at some of my data now with a different view, and you will probably see what I mean. The setup of my talk is very simple. The two headings are the gate wide open and how to close the gate. Why do I think the gate is wide open? Because we talk so much about chronic pain and about how prevalent it is. And when you see the epidemiological numbers, you're really afraid and you think it's getting more and more, isn't it? Not only do we talk a lot about chronic pain, but also we talk about pain with no obvious etiology. And we now even have a name for it. And this is the official ISP terminology to call such pain chronic primary pain. And there is also the term nociplastic pain. And I put some information on the term nociplastic pain, which means that something happens in the brain that the pain circuits are altered. And in this case, I would say on the right with the nociplastic pain patient, the gate is really wide open so that all the stimuli can come in and nothing is stopping them. And the conditions that are considered to have such nociplastic mechanisms underlying them are conditions with diffuse sensitization or pain like fibromyalgia, visceral pain like the irritable bowel syndrome, other regional somatic sensitization like the complex regional pain syndrome or the temporomandibular disorder, where the chronic non-explained pain tends to stay in one region, but nevertheless is very annoying and really reduces the quality of life. Let's have a look at the definition of chronic primary pain as published here with the first author, Michael Nicholas, in Pain. This chronic primary pain persists or recurs for longer than 3 months. It is associated with significant emotional distress like anxiety, anger, frustration, depressed mood, and or significant functional disability, thus that the pain interferes with the activities of social life, of daily life, and the participation in social roles. And of course, the symptoms are not better accounted for by any other diagnosis, otherwise the pain would not be primary. The authors also say that chronic primary pain is multifactorial, so biological, psychological, and social factors contribute to the pain syndrome, and the diagnosis is appropriate independently of identified biological or psychological contributors, unless another diagnosis would better account for the presenting symptoms. What they want to express with this term is that it's a pain we can describe. We don't really know where it comes from. And the term is supposed to be agnostic with regard to etiology, in contrast to similar or previously used terms like psychosomatic or somatoform, which already imply that we know something about the etiology. And thus the term is supposed to avoid the dichotomy of physical versus psychological. Also, it avoids the term non-specific. One could have called it non-specific pain, but it's not a friendly term. It also avoids the term functional. For some people, especially in Germany, the term functional means it's all in the mind, whereas for others, it's just a disorder of function, and it would be a more neutral term for the physiotherapists. Functional is more a disorder of function, but for many neurologists, psychiatrists, it's in the mind. And another purpose of this term is to make this chronic pain visible, to have a way to classify and count the chronic pain. And this is from a German journal, Der Nervenarzt, where Paul Nilges and co-authors also celebrate this new term, saying that it's finally making chronic pain a diagnosis, and that chronic pain is neither a mental nor a functional disorder, but in the new classification, the ICD-11, it is finally an independent diagnosis. And this tree of chronic primary pain entails chronic widespread pain, complex regional pain syndrome, chronic primary headache, visceral pain, and chronic primary musculoskeletal pain. And I'm picking out one of them. Under the chronic primary pain, you have the chronic widespread pain, and you have fibromyalgia, which is, by this classification, a chronic primary pain. You all know what the fibromyalgia syndrome entails. It's chronic widespread pain, which means over 3 months, with pain on both sides of the body, above and below the waist and in the spine. And in the past, we needed tenderness upon manual palpation of at least 11 out of those 18 tender points. We don't need it for the diagnosis now anymore, but it's still useful to do. What we do need to make this diagnosis is to have some associated symptoms like unrefreshed sleep, fatigue, depression, cognitive or autonomic symptoms. And there are some theories about the pathophysiology, which, as I tried to show you, is compatible with calling it primary, because we don't really know, but we have found some physiological changes like a neurotransmitter imbalance, an altered HPA axis function, a CNS hyperresponsiveness, which show us that something is happening in the organism in this condition. And there have been lots of hypotheses on the pathophysiology saying that it's the result of central nervous system malfunction resulting in an amplification of pain transmission and interpretation, which would be a very open gate. Others are saying that it also depends on peripheral nociceptive input as well as abnormal central pain processing. So again, it would be an open gate, and the other two definitions are not very different. We did some research on patients with the fibromyalgia syndrome. For example, we applied pressure stimuli to the right forearm. We looked at the pain thresholds, which were reduced in fibromyalgia patients as expected, reduced compared to healthy controls and to people with depression, because some people still say fibromyalgia is just some kind of depression. So this is why we had a disease control group of people with depression but no pain, who have normal pain thresholds. And although the fibromyalgia patients perceive pain at this low threshold, the subjective pain intensity is already very high. And we used near-infrared spectroscopy, putting these optodes on the head and measuring the oxygenation of the cortex as an indicator of brain activity. And when we applied the stimulus to the right forearm, the fibromyalgia group had higher contralateral activity in the brain than the controls and the disease controls, but also had some ipsilateral activity, which was unexpected. So something is happening between the periphery, where the stimulus is applied, and the brain, where the sensation of pain and the activity of the brain are measured. And where is this happening? It could be happening right at the receptors in the periphery. It could be happening in the spinal cord. It could be happening anywhere in the ascending or descending tracts. And of course, it could happen in the brain itself. We tried to come a little closer to answering this question using a number of methods. One method we used was quantitative sensory testing, applying these heat and cold stimuli, the von Freiherrs, the vibration, the pinprick, the pressure, in a systematic way to the patients. And surprisingly, our fibromyalgia patients had a reduced sensitivity to cold and warmth and differences in temperature. Thus, they had increased thresholds for these stimuli. And they also had increased thresholds for the von Freiherrs. They had decreased thresholds for pressure with pinprick and the dull pressure as expected. So this was expected, but that they were less sensitive to some stimuli we had not expected. And now, when we perform quantitative sensory testing, we apply the stimulus and we wait until the patient reacts. So again, we are testing the whole tract from the periphery to the brain. We do not know whether this is caused by a dysfunction of the small nerve fibers in the periphery or a gate dysfunction or both or anything in the brain. We got a little closer by looking at skin biopsies. We took these skin punch biopsies, stained the nerve fibers in the epidermis, counted them, then you get a count of fibers per millimeter, and this count was lower in the fibromyalgia patients compared to our controls, and our depression patients were not lower. And this was true for the punch biopsy at the lower leg and at the upper leg. Why is this important? As you know, I'm a neurologist, so I see many patients with neuropathies, also with small fiber neuropathy. And the typical finding is that the more distal areas are more affected. So that the skin innervation in the lower leg would be pathological, but in the upper leg it would be normal. And here it was not so. They were reduced in both the lower and the upper leg. And at the time, we were very intrigued by the findings of Jordi Serra's group, who did microneurography with these patients and found increased spontaneous activity in C fibers of both patients with fibromyalgia and with small fiber neuropathy. Also increased mechanical sensitization. So there, the fibromyalgia and the small fiber neuropathy, which is a different disorder, but they have in common that they have reduced skin innervation, and some of the pain characteristics are also similar, but they are also very different, as you see here on the right. So the fibromyalgia patients have pain all over and in the big muscles and in the joints, and the small fiber neuropathy patients, they have pain typically in the feet and in the hands, in the distal nerves. So one thing in the microneurography was different between the fibromyalgia and the small fiber neuropathy patient, which was the activity-induced slowing. Activity-induced slowing is a characteristic feature of C fibers, and people doing microneurography, they use this feature to identify the C fibers. So C fibers normally do this. They have a slow conduction anyway, and if you activate them, they become even slower. This is normal, and it happens in the normal controls, and it happens in the small fiber neuropathy patients. But in the fibromyalgia patients, this slowing became even more. So their C fibers became even slower upon activation. And thinking, I'm not showing this, but I'm telling you, thinking about why this could be, we discussed that it might be because the C fibers of our fibromyalgia patients are even thinner than normal, healthy C fibers. And indeed, we did an electron microscopy study with skin biopsies from a new cohort of patients, and we could show that our fibromyalgia patients had thinner C fibers in the skin than normal controls and patients with small fiber neuropathy. In the meantime, we collected a new cohort of patients with fibromyalgia. You see, it's over 100. We collected a new cohort of disease controls. This time, they had a major depressive disorder and chronic widespread pain. This is what the gentle reviewers of our papers urged us to do, but it was a good idea. We took the skin biopsies again, and now, since we had a larger group, we could look at some subgroups. Maybe you look at the right side first. These are normal controls, and 82% had a normal skin innervation at the distal and proximal leg. This is what you would expect. 13% of our normal controls with no symptoms, no diabetes, normal blood values, everything, had a reduced skin innervation at the distal leg. It just happens, and it's part of the normal that not everybody is within the normal range. But only 2% had reduced skin innervation proximally, and the same for the very small group who had reduced skin innervation both distally and proximally. Now look at the fibromyalgia cohort. 37% have a normal skin innervation. So our skin biopsy test is not a test for fibromyalgia. Many patients ask me this, can I have the test for fibromyalgia? It's not a test. 37% are normal. 17% have distally reduced skin innervation. 31% have proximally reduced, and these 15% had distal and proximally reduced skin innervation. And these were also most severely affected. In all the scales and scores that we took, this subgroup was most severely affected. So why is a very much reduced skin innervation in both areas associated with more pain, more being affected by the disease? We tried to find out. But first, just a few more findings. Skin biopsy is a bit invasive and not everybody likes to have it repetitively. So we're always trying to use less invasive methods like the corneal confocal microscopy, where you can look at the innervation of the cornea non-invasively. And there's several parameters like the branchings and the number of fibers here, and these were also reduced in the fibromyalgia cohort. And we use a special type of evoked potentials. They are caused pain-related evoked potentials, PrEPs. In fact, they are a delta fiber evoked potentials. With this small concentric electrode, you evoke potentials through the stimulation of a delta fibers, and you get a potential with a latency and an amplitude, and the amplitude is reduced in fibromyalgia patients. We found this in our first cohort and also here in our second cohort. And this time we could invite Jordi Serra to come to our hospital and to investigate our fibromyalgia patients and controls using microneurography. He was blinded. He was not allowed to talk to the patients. We always had a postdoc watching him, that they did not tell them whether they were controls or patients. And he could confirm that there is increased spontaneous activity and mechanical sensitization in the C fibers of the fibromyalgia patients. It was funny because so often he put the recording needle in and he heard the sound from the activity of the fiber, and he said, "You can't fool me, this is a patient," or he said, "This is a control," and in 95% he was right. Okay, I would like to go to the brain. It has been shown in fibromyalgia and also in other chronic pain that the brain is not only functionally changed, but that it can be morphologically changed in chronic pain. And what has most often been shown is a decrease in some areas, for example, a decrease of cortical thickness. And in our cohort, oh, I'm sorry, this is a mess. In our cohort, we found exactly this decreased cortical thickness of the left pars opercularis in fibromyalgia patients compared to the healthy controls, and we had about 40 and 40 using voxel-based morphometry. But this had been shown before, so it was just confirmatory. But what we were more interested in was whether there was a difference between our two subgroups with the extremes, those with the normal peripheral skin innervation, so I would say the normal peripheral nervous system, and those with the greatly decreased, generally decreased skin innervation with the more prominent peripheral nervous system involvement. And the result was that those patients who were more affected in the periphery were also more affected in the brain. They had more regions with reduced cortical thickness. Actually, this was in contrast to my hypothesis. I would have thought there's a peripheral type. I have to show this. There's a peripheral type of fibromyalgia. They have a problem in the peripheral nerve fibers. They have the fiber loss. They have the spontaneous activity in the C fibers. And there is a centralized type of fibromyalgia where all the wrong processing is in the brain. No, it's not so. Those who are more affected in the periphery are also more affected in the brain. And now I understand it. Why is this so? Because the gate is open and all these this activity, this nociceptive activity from the periphery comes to the brain unfiltered. Yeah, the question is still, does this continuous peripheral activity in the nociceptors keep the gate open, or is the gate open for another reason? I don't know. Of course, we are also interested to find out what is the cause of the peripheral pathology and activity. Is it a primary defect or pathology in these C fibers, or is it an imbalance in inflammatory mediators? And I just told you this before. This difference in the activity-induced slowing brought us to look at whether the C fibers are too thin. We had a new cohort with fibromyalgia and with small fiber neuropathy. And these are some electron microscopic sections through human skin. On the right, the controls. You can see the C fibers here nicely in their Schwann cells, and you can see the diameter. And on the left, this is skin from a fibromyalgia patient, and you see the C fibers are smaller with smaller diameters. And just for your interest, this is the myelin from a myelinated fiber. You can also see these very nicely in the skin. And the whole thing quantified by Katrin Doppler, who was then my postdoc and who did all this analysis in a blinded manner. You can see that whether you take the skin at the distal leg, proximal leg, or at the finger, we also took some at the finger, the diameters of the C fibers in the fibromyalgia patients are always smaller. Why this is so, we do not know yet. We did try to find some factors that might explain it. For example, we used one project where we had collaborators who looked at non-coding RNAs to get a non-coding RNA array profile of the skin of our fibromyalgia patients. And there was one non-coding RNA, the microRNA LET7D, that was different in fibromyalgia and control. And these are white blood cells. We did all the analysis in parallel in skin and white blood cells. But this was out of these that we found in the array. This was the one that was also confirmed by qPCR. So we looked at this a little further. This is the increased expression of this LET7D in the skin of fibromyalgia patients. And so this is what you then do and what the doctoral student did. You look at a database for the targets of these microRNA. And one of the targets was the insulin-like growth factor receptor 1, which made sense because this is a growth factor receptor that could be responsible for how the fibers in the skin grow and regrow, because they have to regenerate all the time or not. And the expression of this insulin-like growth factor receptor 1 was indeed different between the two areas in the fibromyalgia patients, and in the distal skin it was reduced. Of course, you need to analyze the protein to see if this really is of importance. We did not have enough material from these small, tiny skin sections to do a Western blot or something like this, but we could do immunofluorescence, and there the IGF-1R was also reduced in the fibromyalgia cohort in the distal skin. So this is what the student set up as a potential mechanism there is some prenatal stress or later life event which might cause the distal skin microRNA LET7D to be upregulated, which downregulates the IGF-1R, which then leads to reduced regeneration of the small fibers in the skin, of their pathology, of their increased activity, and then to pain. It's definitely not the only pathway relevant in fibromyalgia, but it might be one. What has been discussed for a long time in this condition, and this comes back to my second point, what could it be? A pathology in the fibers themselves, or a pathology in the milieu that they are in, and thus an imbalance in inflammatory mediators. And for example, in this systematic review, you can see what we also found in our cohorts, that these patients have a biased profile such that they have more pro-inflammatory and fewer anti-inflammatory cytokines. And in our cohort, we found reduced levels of interleukin-4 and interleukin-10, two anti-inflammatory cytokines. This is at the gene expression level. We also found it at the protein level, and this was in blood, just systemically. So they had fewer, a lower expression of anti-inflammatory cytokines. And just to show you that this is not natural, that everywhere you look, you find this, because when we had this systemic finding, we then thought, well, if even in blood they have reduced anti-inflammatory cytokines, then in the skin where locally the pathology happens, we have to find this even more. We have to find this even to a bigger extent, but we didn't. We looked at cytokine expression in the skin in our fibromyalgia patients, controls, and depression, and we did not see a difference. So it was a systemic finding. But then we thought, well, maybe there is something in the skin, but we don't see it, because if we measure mRNA of the whole skin, we lump all the cells that there are. There are very few axons, so we wouldn't see much RNA from those axons anyway, but there are lots of fibroblasts, there are lots of keratinocytes, there are blood vessels, and findings might be hidden because something is upregulated in one cell type and downregulated in the other. So we went on and separated fibroblasts and keratinocytes in cell culture and looked at the expression of these cultures. For example, in the fibroblasts, we found an increased expression of TGF-beta1 in the fibromyalgia, and we found a certain channel, HCN2, and we found these ephrins, FNA4, FR4, increased in fibromyalgia. I will talk a little more about these in a minute. And in the keratinocytes, for example, we found increased interleukin-10, and again, these FNA4 and FR4. What are these? They belong to the ephrin family of receptor tyrosine kinases, and they are receptors, and their ligands are axon guidance molecules. In the skin, we have attractants for the nerve fibers, because as we shed our skin, all the time we have to regenerate these small nerve fibers. So we have attractants that bring them into the epidermis. We also have repellents so that they don't grow too much. Okay, we don't want a neuroma there in the skin. And the right balance of the attractants and the repellents and the receptors makes our epidermis always nicely innervated, just enough. And with these findings, we now hypothesize that in healthy skin, there's a balanced expression of the repellents and the attractants and the receptors. And in the pathological skin, there is an imbalance, and there may be more repellents than attractants, and this is why the fibers don't find their way to the keratinocytes into the epidermis. Yeah, these are all quite complicated findings that are very small pieces in the big puzzle of chronic pain and of fibromyalgia. And maybe it is much simpler. We know, I think I could show you, that the fibromyalgia patients have ongoing nociceptor activity, but do they also have reduced non-nociceptive input? So according to the gait control theory, the large fiber input should be reduced, and thus the gait would not work properly. Now, I cannot tell you this because the large nerve fibers in the fibromyalgia patients, they work really well. We studied them with standard neurophysiology, also with the standard neurological tests. We cannot find any fault in the large nerve fibers. But maybe we need not only look at the large nerve fibers, because there is another type of tactile fiber, the C-tactile fibers. They are C fibers. They are as small as the nociceptive T fibers, but they are tactile fibers, and they are responsible for the pleasantness that we sense when something or someone slowly, gently strokes our skin. And you can model this by using a calibrated brush, and you can ask the participant for the pleasantness of the brushing on a scale of, we did it from -10, very unpleasant, to +10, very pleasant. And in most control persons, this gentle brushing is perceived as very pleasant, and only very few say it is unpleasant. Also, in the majority of the fibromyalgia patients, it was perceived as pleasant, but there is quite a substantial minority that called this gentle brushing unpleasant. So I don't know if this is important and how valid it is, but there seems to be a reduced C-tactile fiber function, again, in a subgroup of the fibromyalgia. And if the C-tactile fibers have anything to do with this, and they may also close the gate, then we might have one more reason why the gate is so wide open in fibromyalgia. So finally, I come to my second part, which is much shorter than the first part because I don't know so much about it. And this is the question how to close the gate. As you all know, the gate is much more complicated than the nice drawing we just saw. And other researchers have tried to sketch this for us to show what the gate might consist of. And I won't try to explain this to you in detail. We looked at where the gate could be closed even in fibromyalgia, because when we looked at our cohort, we found some very different types of patients. You have here pictures of women because most patients are women. And there was the one type, the superwoman, the businesswoman, who does everything in spite of the pain. She says, yes, I have this, but still I have my children, I have my job, I'm doing this, I'm doing that, but please help me get rid of this pain. But she's coping, she's doing all of this. And we have the other patient who is suffering so much, who the family falls apart, she loses her job, and she's really going down the spiral. And we were looking if we could find any predictors, any parameters that would tell us why is this one person coping so well and the other one not. Since we had some funding from the, it's called Evangelisches Studienwerk, so it's a Protestant foundation, we also looked at the role of religiosity, which disappointingly was not very high in the difference between these two. But what did come out of this study was that we could identify by cluster analysis 4 clusters of fibromyalgia patients, which according to these factors, the affective load, the coping, the physical functioning, and their load of pro-inflammatory cytokines, we could name as maladaptive, adaptive, vulnerable, and resilient. So it doesn't tell us yet why they are like this, but it confirmed our impression that there are these different types, and it showed some factors that contribute to it. And so one of the questions was whether religiosity had anything to do with it, which it did not. You see, the coping strategy, hoping, praying, is quite equally distributed between the maladaptive and the very resilient persons. The one thing that was different was that the vulnerable group was higher in catastrophizing. And I think this is not a surprise at all, because it happens in many pain studies. From this, we developed some ideas for individualized therapy. So, for example, the maladaptive cluster might benefit from cognitive behavioral treatment, exercise training, and anti-inflammatory treatment, because they are in a pro-inflammatory state. And for example, the vulnerable cluster might or also benefit from positive activity intervention, and so on. So maybe if we go along this path, characterizing our patients not only by the molecules we find in the blood, but also by these coping strategies, may help us find individualized treatments that help them better close the gate. What else could we do? In a new series of projects at our institution, we are looking at pain resolution. We want to learn from those patients who get better, what happens with them, and we want to see then if we can extrapolate the mechanisms that help them get better to those that don't. For example, in the complex regional pain syndrome, you have some patients who never get better, they have chronic pain all the time, and you have patients who get better, where there is pain resolution. And we managed to get 19 PIs together at our institution who are all motivated to look into this pain resolution. And we applied for this grant and we got it. And now we are lucky that we can work on all these projects. For example, I already mentioned it. We are looking at resolving and non-resolving CRPS. And we are looking at the biological, psychological, any factors that might be behind it. And we have some other model diseases, for example, a chemotherapy-induced neuropathy, which also gets better and resolves in some patients and in others not. We have neurofibromatosis, which is painful in some and in others not. And what links all these projects is the question, why does pain resolve in some patients and persist in others? And just some example, restoring the neuroinflammatory balance. I already told you about the imbalance there is, might help lead to resolution. This was a study on patients with nerve injury. So an ulnar nerve or a sciatic nerve were injured by trauma. And we looked with deep sequencing whether they had a different gene expression in those who had pain and those who did not have pain. About 50% of patients with a nerve lesion have pain. The others have not. Those with pain were the NL1 patients who had increased interleukin-1 beta gene expression. So sometimes it comes back to the same mediators, pro-inflammatory cytokines. Although we looked at so many genes, this one came out. Or, for example, when there is increased spontaneous activity, what can we do to reduce this activity? This is an example from another painful disease, Fabry's disease, where some patients have immense heat and activity induced pain, and we are working with the mouse model and giving the enzyme that is missing in these patients, and we could not completely restitute, but we could alleviate some of the pathologic activity in the nociceptors. And the chemotherapy-induced neuropathy, that's another example, which is very nice because you can model it in Drosophila and in the mouse. And of course, we have the humans, so we're using all these systems to find out why do some patients get better and others not. Another example is one by my colleague Heike Rittner, who looks at the blood-nerve barrier. The blood-nerve barrier is disturbed when you have a nerve injury in the animals, for example, the chronic constriction injury, and this induces pain behavior in the animal, and giving one adhesion molecule, netrin, closed the barriers and reduced the pain. So restoring the blood-nerve barrier might also be one way to close the gate. And this is also an interesting example. There is this molecule called SIRL, which the Drosophila researchers are very excited about because it is involved in sensory signaling, and it can exert opposing effects on low threshold mechanoreceptors, which means if it is present, it increases the response in low threshold mechanoreceptors of Drosophila, and at the same time, it reduces the activity in high threshold nociceptors. Now, if this isn't a very nice example of the gate, I don't know what else I can show you. And of course, we haven't closed the gate. Maybe we found that it's much more complicated. Maybe we are thinking in a too complicated way. At least we found some pieces to the puzzle. And whether we are nearer to closing the pain gate, I have to leave the question to you. I think we better understand the complexity. We better understand the many modulators, and what is my pet project right now, I think you already heard it, is to understand how the organism itself helps close the gate and learn from that. And with this, I thank my many collaborators and students and the funding agencies, and I thank you very much for your attention.